Welcome to In Session, the North Carolina Healthcare Association's podcast where we dive deep into critical issues impacting hospitals, patients, and the overall health of our communities. Whether you're a legislator, policy advisor, or community leader, this series is designed to keep you informed about the challenges and opportunities in healthcare today.
I'm your host, Alicia Barfield, Director of Policy Development. On any given day here in North Carolina, at least 360 patients medically cleared for discharge from the hospital are waiting to be transitioned to another care setting, like an assisted living facility, home health services, a long-term acute care facility, and most notably, skilled nursing facilities. Our guest today has a lot of experience in helping patients transition to the proper environments and understanding the barriers patients and hospitals face with post-acute care transitions. Katie Flanagan is the Assistant Vice President of Care Coordination at Duke University Health System, where she leads case management services across Duke Health. Katie also chairs our Transitions of Care Committee here at NCHA. The NCHA Transitions of Care Committee is comprised of case management leadership across the state. This committee works to address opportunity areas to improve post-acute care transitions for patients. Thanks for joining us, Katie.
Thank you for having me, Alicia. I think this is going to be fun. I've been really looking forward to this conversation. We're talking about a subject that is near and dear to my heart, so thank you for having me.
Before we jump in, let's take a quick look at the numbers. On any given day, at least 360 patients ready to be discharged in North Carolina hospitals cannot leave because there's no placement available. More than half of those patients, 57% to be exact, are waiting to be placed in a skilled nursing facility. Most patients are waiting an average of 73 extra days. That's more than 10 weeks. This data comes from a study conducted by the Transitions of Care Committee. Katie, help us understand this. Were you surprised by these findings? And what challenges are skilled nursing facilities facing that lead to these discharge delays?
Alicia, thanks for that question. I have to start by just saying how much I appreciate you and the case management leaders throughout North Carolina who serve on this committee. I know I've learned a lot walking beside them and the team. It's energizing for us to really try to wrap our minds around what's going on in North Carolina. And so we've collected a group of real problem solvers who want to fix the solution as opposed to just talk about it. So I think that North Carolina is lucky to have this case management leadership group helping lead the way. So I know the numbers are staggering, but I actually am sad to report that I wasn't surprised by the outcome. It's amazing to think that we could fill an entire hospital with the patients who are just waiting for a post-acute option. And I want to mention, because we talk a lot about this in our committee meetings, that there are many, many patients beyond that who are staying in hospitals for an extra 1 or 2 weeks. More than they need to be there clinically because of barriers we're facing with transition. So what we're going to talk about today and the population that the committee is really focused on in this study are those that are staying in our acute care hospitals for a very, very long time. As you mentioned, 73 extra days because of the fact that they have such complex medical, clinical, or psychosocial needs. So what I would say about the nursing homes is that I don't think they feel equipped to manage this population, and I don't think that they're currently receiving the compensation that they would need. It just feels like it's simply not high enough for them to have the resources needed to take care of all of the patient needs or to build out the programs. So currently, there really isn't an incentive for the nursing homes to build out these programs. They were originally designed certainly for the aging without the complexity of all the new technology happening in hospitals. And in order to take care of really complicated patients, the facilities are, really going to need a lot more support than we're giving them currently. And I think that they're fearful that they're going to end up penalized because of some of the current regulatory expectations. So they'll talk to us about rules around the use of psychotropic medications, for example. So if they are prescribing a significant amount in the facility, then they will get increased scrutiny. So if they start more routinely admitting a population of people who are living with schizophrenia or who need psychotropic medications to treat their illness, they would need to be supported in making that available to their patients without being worried about being penalized for that. Or if they accept more patients with dementia who have co-occurring behavioral outbursts, the facilities would also need to feel confident that they're not going to risk their star rating if one of the patients does have a behavioral outburst. And so there's a lot of factors, I think, that go into the barriers to nursing homes taking these patients currently. And the people who run and work in nursing homes do it because they love caring for the disabled and the aging population. This is their passion. And so they want to do it well. And I think the real barrier is we need to give them the tools to do it well.
Thanks, Katie, for breaking that down for us. As you mentioned, there are several factors that seem to contribute to the longer delays. You mentioned specifically the behavioral health factors. I know in our data study, we found that about half of those waiting for skilled nursing facilities also had a behavioral health diagnosis. Are there any other complex clinical care needs that you'd like to mention as well that skilled nursing facilities are not necessarily equipped to manage at this time?
There are quite a few, and that's what makes this even more complicated to come up with a program around. So I'll try to break it down into a few different populations and talk about the complexities. I'll start with the patients with high respiratory care needs. So that population includes both people who need oxygen at a higher volume than most nursing homes are equipped to deliver, or ventilated patients who require a lot of respiratory support and clinical expertise. So the very large majority of our nursing homes don't have respiratory therapists on staff to support this population. And we now only have 2 facilities in the whole state of North Carolina that can offer the care for patients on ventilators. We used to have 3, but last year we went down to 2. And so as you can imagine, both of those have really long waiting lists for admissions. And what I hear from the skilled nursing facility community is building out the infrastructure needed to manage that population. It's highly specialized, it's really expensive, and thus far the reimbursement isn't high enough to motivate facilities to build out the capabilities. In addition, outside of one facility that has 6 dialysis slots, our skilled nursing facilities are not currently providing dialysis within their buildings. So you can imagine trying to transport a patient with high respiratory care needs who also needs dialysis 3 times a week would be quite a challenge. And so understandably, it's a lot for a nursing home to take care of. And so patients and families right now are really facing incredibly difficult decisions about what to do next, because currently the primary option is leaving the state of North Carolina. And that is not an easy pill to swallow if you are wanting to be close to your loved one, but you can't take care of them at home and there's not an option here. The second population, I do want to expand a little bit on the behavioral health population. So meeting the needs of our patients who are living with both behavioral health concerns and medical needs is really complex and multifactorial. So I'm excited that the North Carolina DHHS has created the new tailored Medicaid plans because they're designed to take care of the whole person. So to take care of people who have behavioral health diagnoses such as schizophrenia and substance use disorders, but they also have co-occurring medical conditions. So historically, we've had a system where an individual would have one Medicaid insurance group taking care of their medical conditions and another taking care of their behavioral health concerns. So this is a promising development for us that they really are creating a group of insurance plans that are going to take care of all of these things under one roof. As you can imagine, though, they are new, and so they're trying to develop contracts, relationships in the communities, and so it hasn't made the transitions of care for this population easier yet, but it certainly is something that we're excited to partner with the tailored plans to build out. But what we've learned from the nursing homes about why they're not currently making bed offers is while they're really skilled and staffed to manage the needed medical care, short-term rehab, long-term care aging populations, they just don't have resources in their building to manage co-occurring behavioral health needs. So what we're hearing is that they would need to bring in supports like behavioral health technicians, psychiatrists, social workers in order to optimally take care of these individuals, or they're not doing them justice. So when we talk about people who are living with a substance use disorder, the skilled nursing facilities, you have expressed concerns like, what if their addiction means they would use substances within our buildings or would have other people bring substances to the building? So the facilities are saying, well, if we're going to move into that world, we would really need to have a funding source to bring in substance use disorder treatment that would be needed to reduce this risk and, again, treat the whole patient population. A third group that I want to mention that's a pretty sizable population as well is that as medical care is advanced and providers are able and hospitals are able to offer more life-sustaining treatments with technology, things have gotten a lot more complicated to take care of in our community. So we don't currently have nursing homes that are able to manage many of the complex needs in the hospital. So another population I just want to mention is our bariatric population. So after an acute hospitalization, it's not uncommon for these individuals to need subacute rehab, which typically happens in North Carolina within our skilled nursing facilities, so that then they can return home and return to the life they want to live. But because of the fact of just their sheer body weight alone demands different equipment, different doorways. Some of the nursing homes were built many, many years ago where the doorways aren't wide enough for someone in a bariatric wheelchair, for example. So making sure that the nursing homes can take care of their staff, they would need specialized lift equipment, and the nursing homes are just not equipped to do that right now. It's extraordinarily expensive to implement. Another population that I think would be helpful for us to make sure people are aware of and that we as a community need to plan around are patients with neurocognitive disorders, patients with Alzheimer's or dementia who have also some behavioral disturbance associated with that. It's really heartbreaking and alarming to families when their loved ones are expressing themselves or managing their own fear and confusion by pushing someone or swinging at someone. We'll often hear family members say, "This is not my mother. This is not what I'm used to." And so it's really common for family members to bring their loved ones to the hospital when these behaviors have become so concerning that the families don't think they can take care of them at home anymore. And so the skilled nursing and memory care facilities have said that even if while in the hospital setting, things appear to have stabilized, we're not seeing any of the behaviors, we're able to come up with strategies to support the individual, they are still very worried that if we move them to a new environment and they start to struggle again, that the SNFs themselves are not resourced to support the patient and keep the other residents safe at the same time. So nursing homes will tell us we don't want to send people back to the hospital, but we also don't have what we need to keep this population safe. So if they're fearful and they're worried they don't have the resources, and they just don't make that offer. So that is another population that ends up staying in the acute care hospital for months and months.
Thank you, Katie, for highlighting what our patient, their families, our partners are facing in caring for this community. And we want to be a partner and find solutions that more North Carolinians can get the care they need when they need it and where they need it. You've mentioned already how we can work together, but how can hospitals, skilled nursing facilities, and payers continue to work together to address these challenges? And are there some opportunities or learnings from other states that we can learn from as well?
Alicia, so this is the part I'm most excited to talk to you about because I know that we can come up with solutions. So we see other states are accomplishing this, and I am confident that North Carolina can do it as well. We've got the right people at the table. There's a lot of energy around it. So we've been talking to a lot of different states to try to better understand what folks are doing. So one of the areas that we've been looking at is Virginia. What we understand is that they have payment models that allow for facilities to build out more of the higher respiratory care need options. And so because of the fact that we've had to transition so many North Carolina residents to Virginia, we have learned a lot more about what they're doing there. And when we talk to the nursing home administrators, they're saying it's because of the fact that they have a tiered payer system, that they pay higher amounts to take care of more complicated patients. And so that is one area that feels exciting to us. Another one that I'm really excited to learn from, and the Transitions of Care Committee has been looking at with help with the North Carolina Healthcare Association, because you guys have really been the ones who've been reaching out to these groups and helping us get connected. But they have a behavioral complex care program. So the Nevada Behavioral Complex Care Program provides specialized services for individuals with these complex behavioral needs we're talking about. It includes mental health, substance use, and co-occurring disorders. And there is enhanced funding that allows them to coordinate support for assessments, treatment plans, multidisciplinary care teams, higher staffing levels like we were talking about earlier. And they had an add-on per diem rate provided for Medicaid in this tiered system. And so basically what we talked about earlier, staffing it to manage the whole person. So the nursing home has the resources that they need to take excellent care of the individuals that they're charged for caring for. So some patients don't need as much help and support while others need a lot. And if we're able to move into a system that acknowledges that and really look at a cost analysis of what it would take to take excellent care of these individuals so that we can reduce harms, reduce staff burnout in our nursing homes, staff turnover, unnecessary emergency visits. I really believe strongly that in the long run, it would be less costly. So building out a program that truly manages individuals well in the lowest level of care would be the ideal solution in my mind. Nobody wants to be in a hospital longer than they need to. And obviously, we want people to thrive in places where they want to be. Another group that feels important to mention is that we've been meeting with is a group out of Philadelphia. They've also built out a successful program. And as of January, they were supporting a new 42-bed wing. So this is something they are also just starting over this past year, but they are about ready to open another unit. So the program's evidence-based clinical model for the care of individuals, again, living with severe mental illness. And it's a structured environment within a skilled nursing facility. And the goal that they set out to meet was to address what they saw as their growing aging population also living with a mental illness. So the same exact thing we're seeing here in North Carolina. And so they shared with us that they filled the beds as soon as they opened them. And they have a waiting list of appropriate patients. And so thus opening the additional unit. That they also shared that they've exceeded the initial cost savings they projected, which reinforces that this is absolutely doable. This is something that we would be able to accomplish. So it was exciting when they estimated the savings for the Medicaid and state behavioral health programs to be over about $3 million for just that 42-bed program. So that was jaw-dropping because what they're saying is the cost savings of patients not staying in the hospitals, landing in jails, overutilizing EDs. Feels pretty exciting to think that means we too would be able to appropriately care for this population who also needs skilled nursing care, not in a hospital setting.
Let's keep the conversation going. Listen to part 2 of this episode now.